All right, today I will be presenting on neurodynamics and neuromobilization. Here's a brief overview of everything that I'll be discussing today. So a little bit of background about neural tissue, the use of neurodynamics. I'll mention a few seminal works and then the strengths and limitations as well. So a neural tension examination is just an examination of the mechanics and sensitivity of the nervous system. It's a term that has been used frequently or historically in the literature. However, in 1995, Shacklock suggested the term neurodynamics instead, suggested it as a more appropriate term because it encourages the appreciation of the physiological process involved in nervous system movement as well as the mechanics. So essentially they're the same thing. Neurodynamics is just a little more specific. So a lot of what this presentation covers, it was presented by David Butler as part of a seminar for the Rehab Training Network. Within that seminar, he has 4 key points that are important to understand about the nervous system itself. And he believes this to be a necessary first step before the design of neurodynamic tests can really be understood and put into clinical use. So that first key point is that understanding that the nervous system is a continuum. There's 3 interrelated ways of that, mechanically through levers, electrically impulses, and then chemical through neurotransmitters. So essentially, if something happens to part of an organ, there's repercussions for the whole thing, but throughout those 3 interrelated ways. Second key point, there is a great need for a physically healthy nervous system. All activities that we do require that nervous system to be mobile and move with us. And the prime role of that nervous system is communication. And that can occur through chemical and electrical means. The third key point is understanding a little bit about the nervous system's anatomical design for movement. Understanding that 40 to 80% of the peripheral nerve is connective tissue, and those connective tissue sheaths are very highly innervated. A lot of nerves going through a lot of tissue. We work a lot with tissue, so we can't ignore the nerves that run through them as well. And that those individual axons have mechanical properties as well. Fourth key point, understanding those mechanical abilities of the nervous system. So understanding that it responds to movement by sliding next to adjacent tissues, and that will increase pressure within the system. He provides a few examples that are pretty interesting too as well, I think. The fact that the spinal canal is 7 to 9 centimeters longer in cervical flexion than extension. So just by flexing that neck, your spinal canal, your spinal cord has to lengthen. And not only that, but the brainstem is also nearly 1 inch longer with that cervical flexion as well. And then also, we've seen a large portion of patients with low back pain have difficulty with cervical flexion as well. A few other important things to understand about the nervous system. It's bloodthirsty. There's the vasa nivorum is what supplies blood to the nerves, and this has to happen in every position, even while the nervous system is mechanically loaded. So getting that blood flow to the area through every position that you as a human move through. Like I said, that nervous system is very bloodthirsty. It takes up about 5% of body weight, but 20% of cardiac output. So a decent amount goes through there. Talking a little bit about peripheral neurogenic sensitivity and how that occurs. So there's injury to the nerve that can be through physical force, whether it's an acute injury that occurs or through postural changes. Can be through ischemia, so an alteration of the pressure gradient around the nerve, direct damage to the vessel itself, or a sympathetic alteration. And then some people are also just predisposed to injury as well, whether it be through disease or other anomalies or occupation. So, as athletic trainers, we need to consider more sport specific things. And one example that I might touch on a couple times throughout the presentation, I currently have a men's ice hockey student athlete patient who is dealing with what I believe to be sural nerve entrapment. And it's just on the one leg in that sural nerve distribution. And I believe that that's due to the hockey skate. So he noticed it right after a game, took off his boot, and had some decreased sensation through that distribution. And that's right where that boot is typically tied very tight and a lot of pressure and pushing off of it, anyways. So that would be one example of how something a little more sport specific can predispose somebody to this sort of issue. So after there's that injury to the nerve, then there's biological consequences. That could be altered fluid movement in both the blood and the exoplasm, which is also just sometimes referred to as nerve juice, or at least that's how David Butler refers to it. And then there's also enhanced mechanosensitivity with development of abnormal impulse generating sites. So after those biological consequences, so that altered fluid movement for within the blood, there's a whole sequelae of pressure gradient alterations, starting with a hypoxic stage or just venostasis. Then if it's sustained, then that can result in a swollen nerve, which is the edematous stage. And then if that continues, then it becomes that fibrous state or nerve entrapment. Looking at the altered nerve juice flow, if you will, if that flow is slowed, then it can't keep those axons strong and the cell body will eventually die, and then the target cells become inflamed. It's also important to touch on ion channels, and this ties into those abnormal impulse generating sites that I mentioned on the last slide. So just a brief reminder that an ion channel is just a piece of protein with a hole in the middle, and it's different types are sensitive to different things, and that's so that can be they can be sensitive to mechanical forces, it can be sensitive to adrenaline or some other things. But those ion channels are in a continual state of remodeling. So the receptor half-life may only be 2 days, and then it remodels and it can change what it is sensitive to based on what the body needs at the time. So for example, after an injury, the body or the system may decide that it needs more adrenaline sensitive ion channels in that particular area. So then that area would become more sensitive to stress. And this is important to understand, especially as we work with those chronic pain patients. If they have a lot of increased adrenaline sensitive ion channels, then it's important to understand how stress can affect the pain experience that they have. And then after axonal injury, there's that pooled exoplasm. And so then greater availability of receptors at that particular site, and that's what becomes those eggs or abnormal impulse generating sites. So a way that we can clinically detect that those sites are present, looking at the area. So usually it'll follow a nerve distribution, either dermatomal or cutaneous. It'll be present along a nerve trunk, so a line or a strip. For example, my patient is along that cutaneous, that sural nerve and it's in like a strip. Sorry about that. All right, and then the quality of pain. So there can be a variation in severity, can be more burning for cutaneous or deep ache for nerve roots, or more of like a paresthesia as well. And then behavior. So behaviorally linked symptoms with specific aggravating or easing positions, There can be a link to physical dysfunction in other tissues. And then a couple different things that can be noted with testing might be that it's a short burst of pain that is finished before the stimulus is removed. It can be that the symptoms remain for a period after the stimulus. There can be like that after discharge or a slow buildup and spread after that stimulus has been sustained for a while. So it behaves kind of different, kind of weird. And then some other less familiar symptoms like spreading pain, refractory periods, spontaneous pain, or if it feels like an itch or some other phenomena. It's also important to note when it might be a little more of that, when it becomes more central sensitivity rather than just a peripheral sensitivity. So this is when input from those C fibers will increase the sensitivity of the whole central nervous system. Sorry, central nervous system. So in that instance, then the central neuron fires more easily. At that point, it's still reversible. However, if it is sustained or persistent, then there reaches these morphological changes with new and inappropriate synapsing. So some patterns of maladaptive central sensitivity would include summation latency. So a high load of repetitive movements might have been a cause of this. And then latency, like a bigger latency period is when the pain occurs later. So let's say you check their range of motion and then afterwards they feel the pain. Some other things would be if it's an unpredictable nature. So when you're clinically chasing the pain, it keeps moving or isn't consistent, essentially. And then pain description in this case, everything hurts and pain is everywhere. The pains have spread. It responds to treatment, but then sometimes it doesn't. It has mirror pains. It's outside of the dermatome or innervation fields. So kind of those just weird cases. All right, so now on to the fun stuff of actually looking at the technique. So a couple uses and guidelines. Neurodynamics can be useful for acute pain, more of a chronic pain state, and then for that central pain state that I was just describing as well. So in the acute pain state, immediately after acute injury or post-surgical, this could be very beneficial to use. That peripheral pain might be more of that like pins and needles description. Anytime that you have bleeding that can occur around that nerve that needs to get moving so that it doesn't cause more of that ischemia or entrapment. So when you're working with more acute pain, you want to start with the uninvolved place. So start away from the side of that acute pain and then work towards it. You can do sliders and tensioners, which sliders would be where you're moving just one end of the nerve at a time. Tensioners would be moving both ends at the same time, so it's a little more intense. But you want to go through a range of motion. Timing can vary. One guideline would be to do it for approximately a minute. But kind of the goal of this stage is to communicate to the brain that it is okay to move and that it's good to move. Looking a little bit more at that chronic pain, this is where those abnormal impulse generating sites are starting to form. So using the straight leg raise or the slump test that I'll describe in a minute here, those might be good tests to check, a large portion of the system. And this time you can go ahead and start on the side of symptoms first. And then the timing, you can do a couple repetitions of it and then also prescribe home exercises. So these patients are going to need, more than just a couple treatments. They'll want to keep doing it at home as well, as per your guidelines. And then once you've reached more of that centralized pain state, this is where you don't really have tissue damage on imaging. It's more of a widespread issue. for these patients, that's you really want to educate the patient first and then have them start working in the neurodynamics. So they need to understand that hurt and harm are the same thing here, that even as they're moving, they might have some pain, but that's not causing more tissue damage. And understanding that is a huge component of this. Especially when you're considering, they might have more adrenaline sensitive ion channels in the tissue. And then it's also important to include other coping techniques along with the neurodynamics as well. Again, to address more of that stress state. All right, so for the physical examination, there's a few base neurodynamic tests. There's the straight leg raise, which we've all been trained on. I'll kind of go into a few more details of all of these, though. You have passive neck flexion, prone knee bend, the slump test, the upper limb tension test. And then I have listed there what major areas of the neural tissue is going to be used or loaded with each of those tests. So just some general notes for all of these tests. You want to think about what is your hypothesis before you do your testing. Are you thinking it's more of a peripheral or more of a central state? So have that in your head and know that as you go into it. Also, you want to know the next general note. You want to feel for barriers to movement. So you want to note where you get that first resistance or if you're getting pain or any other symptoms. And you want to assess the quality of movement through that as well. You want to make sure you have a consistent starting position each time. You want to know any pain responses. You want to watch for antalgic postures during the test. So, for instance, if you're doing straight leg raise, if they're hip hiking to try to get more movement. Of course, you always test bilaterally. And then another important thing to note that I'll talk a little bit as we go, or I'll mention a couple times probably as we go through, is that you can change up the order of these tests as well in order to stress different areas more. So first, the slump test, you have your starting position is going to be just seated. Then you have that thoracic flexion, neck flexion, knee extension, ankle dorsiflexion, and they can add that neck overpressure. I'll be sharing this PowerPoint with everybody. So my hope was to have this as kind of a good quick reference as well. And then we're also provided that reference over the summer that has been super useful as well for just a quick check and see, which tissues, what you want to treat and how to do that test. But for the slump test, so some indications might be if the patient reports that their back hurts when they're getting into the car or as they're doing a soccer kick. Think of any of those movements that create a slump as they're doing it. So when you're sitting down to get into the car, you're ducking your head, you're slumping forward. That's that slump movement. There are a couple of variations, so you can add ankle dorsiflexion. While they're in that full slump, you can increase the trunk flexion. You might try adding some lateral flexion, or if there's a little more of like that lateral leg or that peroneal involvement, then you might try adding ankle plantar flexion instead of dorsiflexion. So these are your base tests, but depending on which nerve or distribution you're trying to test, you might change it up a little bit. Oh, I'm sorry. And then one more note on that. So neuromobilizing program, how you want to treat it if you have positive findings. You can teach the patient to do a self slump. So while they're sitting on the bed, they can hold behind their knee and then extend their knee while flexing their head. And you can do either a slide or a tensioner. So as they're holding it, they can extend the knee and then flex the head, or they can do them simultaneously, moving toward each other and away from each other. So I'm trying to show you guys, but you can't really see the whole thing, but I'll try to give a few more examples as we go throughout here as well. All right, next, the straight leg raise test. This is going to be your routine straight leg raise where the clinician is passively raising it. Now, with this test, there's a lot of different variations to hit the different cutaneous nerves. So you add ankle dorsiflexion and eversion to get more of the tibial nerve. If you're doing more plantar flexion inversion, you'll get peroneal. For that sural nerve, you're going to do the ankle dorsiflexion with inversion. And then if you have that hip adduction and internal rotation and a little bit of lumbar flexion, you can get more of that proximal sciatic. So again, these are just different movements. If you understand the nerve and where it innervates, you can test it different ways, load it different ways. So back to the patient that I mentioned earlier, this was one of the things that I was able to do to help narrow down that it was the sural nerve that was impacted, because when he had that ankle dorsiflexion and inversion, that's when it was reproducing or creating some tension, having symptoms. Initially, I had peroneal involvement as a differential diagnosis, but he didn't react with the plantar flexion. And then I dorsiflexed, and that's when we got the tension issue. So it's a great way also to kind of examine and figure out which tissue you're working with, and then you can treat it from there. Big note here, the area that you take up first in the movement is the area that you feel the most. So if they're having more distal issues, then you might try stressing at the ankle for the straight leg raise, you might try stressing the ankle first and then doing that passive leg raise. If they're having more sciatic issues, you might do the straight leg raise test first and then you go do the ankle movements from there. All right, then there's the upper limb tension test. So it kind of goes through the pictures there of the positioning that you want to do with them. This is going to hit the ulnar nerve for sure. Or at least the pictures kind of give you that ulnar nerve distribution. And then there's a couple other variations in that handout that we were given this last summer for how to hit more of the medial nerve, the radial nerve, the musculocutaneous nerve. So there are some different variations there as well. For the neuromobilizing program, a couple exercises, I guess you could say, to have them do if these are the findings. So for example, the ulnar nerve, you can have them put their hands on their hips and then rock side to side, moving up the sides of the trunk. That would be one to get that ulnar nerve, some tension and load on that. Or there's the old making googles with the fingers and putting them up like this. That would stress that as well. So then you can just have them go back and forth. That medial nerve, you can do finger and wrist extension and swinging. So you might have them hold, if it were a right-sided pathology, hold those into extension and then swing through that movement. And you can even try doing it like one finger at a time and swinging through like that. For the radial nerve, you might try shoulder internal rotation. So here, essentially, you do that one more time. You have your hands facing each other, internally rotate, and then holding hands, and then you swing through that flexion and extension. So that's a way to mobilize through that radial nerve. And for the musculocutaneous nerve, you're holding that thumb and that finger into flexion, and then swing back that arm into extension. So you're swinging back that way. So these were some examples that David Butler had given as part of his seminar. So yeah, good things to try there. A couple other general points. Don't stop at the nervous system. This was something that David Butler had hit on a lot. You want to look at the health of all of the tissues along the entire nerve path. So again, everything is a continuum. everything is going to relate to each other. So this is something that should be combined with your normal therapies. In order, you're going to get so much more out of it if you're combining treating the nerve and the soft tissue and the joint all together. Also, a positive test does not automatically mean that the problem is in the nerves. It could indicate that it's more of a central sensitization. And then for the nerve mobilization programs, I mentioned a little bit earlier, you have sliders and tensioners. Sliders are where you're going to have tension on one end and slack on the other end. That could be useful for more of your post-op or nerve irritations or entrapments, maybe a little bit more of the acute stuff. And then tensioners, you're placing tension on both ends. That's going to be for more of your chronic conditions. You can be a little bit more aggressive when it's become that chronic case. Another really interesting thing that I would love to do some more research on and start implementing in my own practice would be to consider using neurodynamics as a pre-sport warm-up. So think about it. I work softball. So with my softball pitchers, I definitely would like to try implementing this to get that nerve moving before they're repetitively throwing at high velocities, making sure that those nerves are ready to move with the tissue. So it's something that I'm excited to implement as I move into softball season. And I think would definitely be good to introduce to them, in that fall season next year. These are just some suggested key readings. It's a lot by the big names in this field are Butler and Gifford, and of course Melzack, talking about just pain in general. But I have a couple references there, and I'm including a couple articles sending out in the email as well for you guys. So strengths of neurodynamics, you're treating the nervous system, which is awesome. It's not something that we think to treat as often or are taught to treat as often. So this is a great way to do that. It's a relatively quick treatment time. It's easily taught for home treatment or self-treatment as well, especially when you have more of those chronic conditions. And then you can see some rapid improvements in flexibility. We've talked before about how hamstring tightness probably isn't actually hamstring tightness, it's probably more of a nerve tension. So if you're able to get the neurodynamics, get some mobilization of the nerve, then all of a sudden they feel way more flexible because they don't have that tension there anymore. A couple limitations, you are treating the nerve, but again, you have to consider the other tissues that are along that entire nerve path, that nerve distribution. You can't just do this alone. You still want to include this in with your other therapies. I'd say another limitation, when you're dealing with that centralized sensitivity and those altered ion channels, it's not going to be an immediate relief. That's why it's so important to educate the patient so that they understand what's going on and why they're having that pain. So I would suggest, we've talked a lot about All Stars, and I think that would be a really great therapy to add in as part of that education piece as well. Other things like meditating and other coping strategies will help treat the adrenaline, the stress side of those adrenaline sensitive channels. And then the last limitation would be, the patients have to actually participate in the home exercises. We've all worked with a lot of different athletes. Some of them are great at doing their homework, and some of them will say, okay, great, thanks, and then never do it. So obviously that's a limitation as well. They have to be an active participant in their own recovery. All right. Well, thank you guys for bearing with me. I know that was a lot of information. I'm excited to talk more about it in class. I'll be sending out a couple articles and some things as well. I think that this is a great technique with a lot of different things that we can use it for. So I'm excited to keep learning about it myself and keep talking about it with you guys. There's some references. And have a good night, you guys.